Hello everyone, it's Melissa Sweet, Public Health Journalist at Croken. We're coming to you live from the National Rural Health Conference in Cairns, and I'm really delighted that we have here Dr. Crispin Hajkovic, who's an infectious diseases physician, and he helped to run a workshop at the conference yesterday on antibiotic resistance. And very interesting to hear some of the similarities and differences arising for rural and remote communities versus metropolitan. So could you tell us, Crispin, a little bit about the situation? You know, why is it an issue for rural and remote health?
Well, the world is facing a crisis in healthcare delivery, and that's the emergence of untreatable bacteria that are resistant to antibiotics. Rural and remote locations use proportionally a large amount of antibiotics. Infections are more common in the bush. And as a result, focusing on rural and remote healthcare facilities and guaranteeing quality antibiotic use is a major priority for the Queensland Government and in the national strategy.
And you mentioned we've heard a lot at the conference about the maldistribution of the medical workforce, and that's an issue for infectious diseases as well.
I mean, there is a clustering of infectious diseases specialists and specialist pharmacists with knowledge in antimicrobials in metropolitan centres, in Brisbane in Queensland and on the coast, with virtually no specialist representation in the regional, rural or remote areas.
So what are some of the areas that don't have infectious diseases physicians? You mentioned some of them.
So there are no infectious diseases physicians outside Cairns, Townsville, Mackay, Rockhampton and Brisbane.
And what does that mean, not just for the management of patients with infectious diseases, but for the burden of antimicrobial resistance?
The whole concept of antimicrobial stewardship has become central to controlling the threat of resistance in Australia, and mandatory antimicrobial stewardship programs have been implemented in Australia since 2014. But it's very important to have specialist knowledge from infectious diseases physicians and from pharmacists, in fact, to run these programs and achieve really good results. And where programs have been rolled out in Australia, there's been a substantial reduction in the usage of antibiotics, and particularly the usage of inappropriate antibiotics that aren't going to make any difference. But it takes expertise and knowledge that isn't currently available in rural and remote Australia.
So what's the answer then? What sort of message are you pushing in the workshop or encouraging people to take away from the conference?
Well, I guess that the main one is that antimicrobial resistance is a real problem, and it's impacting patients in Australia and regional and remote Australia right now, and that of the responses, quality use of the antibiotics we still have, quality use of the antibiotics that are available now is critically important, and that there is individual patient harm every time a patient receives an inappropriate antibiotic, and that happens unfortunately in Australia. In primary care, we use antibiotics more than any other healthcare service in the world, and we think that probably a significant proportion of the antibiotics that are dispensed in the community are inappropriate and unnecessary, and they're treating primarily viral infections.
Could you put a figure on that?
Some of the data we've got suggests that Australia uses more than 1,000 antibiotic prescriptions per 1,000 people per year, and there are estimates between a third and a half of all of those prescriptions being unnecessary or excessive.
And you mentioned when we were chatting earlier that we've had national standards governing hospitals and other sort of acute health facilities to try and have better management and use of antibiotics, but not so much in the community.
No, there are no overarching community healthcare standards for antimicrobial use at the moment. That's something obviously we would like to see progress down the track. And I think GPs and primary care clinics are doing their absolute best under the circumstances, but with all the competing needs that they have, there is a potential gap there, and that support, programmatic support, things like education, auditing and surveillance are going to really help primary care practitioners achieve better antibiotic use without a large investment in time.
And you mentioned that the benefit-harm ratio for patients is probably not well understood. Can you explain more what you mean about that?
Well, I guess we've seen antibiotics for so long, seen penicillin as such a magic bullet solution, without much toxicity, but there are toxicities. More importantly, every time you take an antibiotic for a particular focus or infection, the bacteria in your gut are also affected by that antibiotic, and over time you will personally develop antibiotic-resistant bacteria in your gut, and then potentially, if you then become really, really unwell with severe infection, pneumonia or a bloodstream infection and need an antibiotic, it may not work at the critical moment in your life when you need that, and it may lead to a really poor outcome.
I guess I've often heard antibiotic and antimicrobial resistance talked about in terms of metropolitan centres, but the idea that it is really a critical issue for rural communities. Do you think that gets enough attention and focus?
I mean, I think there's probably is an emerging awareness of big regional differences in antimicrobial resistance. But for example, there are regions in Queensland where the rate of resistance of MRSA in Staph aureus is 50% now, which is higher than anywhere in the metropolitan centres, and really meaning that we're needing to change antibiotic plans in regional and remote Queensland right now.
What does that mean practically for the patients who are getting that high rate of resistance?
It means that the frontline antibiotics that we used to rely on won't work anymore, and we have to use alternative antibiotics which are potentially either less effective or potentially more toxic.
And so I guess the treatment, they're having delays in getting effective treatment?
Potentially yes, but and also that the complexity and burden of treatment becomes more difficult as well.
So what are the messages you'd like readers to take away from Croaky?
Well, one is that antimicrobial resistance is a real problem that's affecting Australians right now, and that it's only going to get worse in the future. The second one is that quality use of the antibiotics we still have is one of the key responses, and that every time an individual receives an antibiotic unnecessarily for a viral infection or for something else, that actually is harming that person and leading to them having a higher likelihood of acquiring a multi-resistant organism in the future and potentially suffering a severe outcome or death from that multi-resistant organism.
Where would you like to see us in a few years' time? What's your vision for if we do manage to make effective gains?
What we would love would be to see, we would like to see hospitals, community, primary care, public health networks all aligned and working together on this problem with a clearly defined research agenda, with excellent quality education and a program of restriction, audit and surveillance of antibiotic use throughout the country. And on top of that, we would like to see a large effort put into consumer engagement and public education, because at the end of the day, consumers drive healthcare, and we know that they definitely drive requests for antibiotic scripts, and them understanding the risks associated with taking antibiotics for viral infections would be key.
We have seen some work along those lines from the NPS and others, haven't we? So you think we need much more?
I think so. The NPS does great work on this, and I know my mum can remember the jingles from the NPS campaign, so it must have penetrated pretty deep. But we'd like to see that ramped up substantially, so that when a patient arrives in a GP clinic in 5 years' time, they don't come with the idea of getting an antibiotic. They come with the idea of being reviewed, make sure they're not critically unwell, understand how long they need to take off school or work, and have a discussion about treatment, but not necessarily an expectation of an antibiotic.
So that's really changing social norms in a way.
Absolutely, yeah. Cultural and social norms around antibiotic seeking behaviour, yes.